Maybe I'll ask you to take that one step further, Neeraj. Which TKI are you using, sunitinib, pazopanib, cabo, for good risk patients?
So even though cabozantinib has not been specifically looked at in the good risk patients, what I gleaned from the CheckMate 214 trial was that VEGF TKIs are active, more active than immune checkpoint inhibitors in good risk patients. So that was the first message I got from the trial. And then my next step is, which is the best VEGF TKI? And there is no doubt in my mind that cabozantinib was superior to sunitinib very clearly in the CABOSUN trial in the first-line setting. Although the patient population was intermediate and poor risk patients, but it was a patient population with a more aggressive disease biology. So extrapolating from that, I think I have no doubt that cabozantinib is my drug of choice for good risk patients.
That tends to be my practice too. I think it was maybe a pragmatic decision that those patients weren't included in CABOSUN, though I agree with you completely there.
So, I'll really counter that and put in, just from a purist standpoint, the CABOSUN trial really only enrolled intermediate and poor risk patients and really didn't enroll the favorable risk patients. And as you say, Neeraj, there are very different, biologically different patient population. And so even though the label does include all metastatic advanced renal cell carcinomas for cabozantinib, I tend to favor using sunitinib and pazopanib in that first-line setting and then holding on to cabozantinib in the second-line setting, and this gives our patients an extra line of treatment.
Yeah, I think I partly agree with you. At the same time, we know the data from IMDC, almost more like 7,500 patients were, and just to give you a background to the audience, IMDC is a consortium of 23 cancer centers, mostly academic cancer centers across the world, and the data were published last year in kidney cancer. 7,500 patients who received first-line therapy, only 51% of those original 7,000 plus patients were able to receive second-line therapy. And then by the time patients, if you look at patients who were receiving third-line therapy, we are talking about like 23% of original patient population. And by the time we are talking about fourth-line therapy, less than 8% patients received fourth-line therapy. So in my view, choosing the best option at a given time point for a given patient with complete disregard to mechanism of action or our personal passions for a given drug or mechanism, and any way we want to describe it, I think we need to choose, I personally need to pick up the best treatment option for a given patient. And if I'm choosing a VEGF TKI, I'm going to choose the best VEGF TKI for a given patient. And based on that rationale, I tend to pick up cabozantinib, even in favorable risk patients.
And I understand, Brad, you're trying to actually gather some data related to cabo in good risk patients, correct?
Yeah, we're trying to gather this data. Obviously, looking at academic centers, a lot of these patients with good risk disease are often put on trials. So trying to find this data in retrospective fashion has been challenging to see truly what is the activity of cabozantinib in these good risk patients. But something we're actively trying to look at. I think I would like to comment though, we are always trying to look to the best option for these patients. And so if I have a patient with good risk disease who comes to my office and says, listen, I really want immunotherapy, I don't think it's wrong to pursue nivolumab and ipilimumab in these patients. When we look at the CheckMate 214 data, yes, the PFS and overall response rates are improved with sunitinib, but there's still an impressive complete response rate in these patients with good risk disease, much more so than sunitinib. Near 10%. So if you have a patient that, if they're that 10% that gets that CR rate, that's the best option for that patient. And unfortunately, we don't have the biomarkers yet to say who are those patients, but I don't think it's unreasonable, to consider immunotherapy in some of these good risk patients. Long-term sunitinib associated with toxicities and, nivolumab and ipilimumab, if they understand the risks associated with that and immunotherapy versus TKI, I don't think immunotherapy is necessarily contraindicating these good risk patients, albeit the data does just that, and statistically speaking, the response rates and PFS are better with sunitinib.
I'll take the moderator's prerogative and just suggest that the challenge here, and Tian, you had a great slide about this on our tweet chat, is that Nivo-Ipi really isn't for the faint of heart, right? It comes with pretty substantial toxicity, you run into about 25% of patients who can't complete the full cycle of therapy, 60% steroid usage. So it's a pretty tough regimen. Thinking about it from the context of being a more tolerable regimen to me is sometimes a little paradoxical. But I'm going to stay on this theme of some of the other immunotherapy regimens we might use for kidney cancer. And Brad, I'm going to keep the conversation going with you. What's your thought on bev interferon and high-dose interleukin-2? These are two regimens we had in years past. Maybe focus on high-dose IL-2. Is there a right patient for that regimen now?
Yeah, I mean, I think bev interferon's been gone for a while. I think high-dose IL-2 is still being utilized just because of that CR rate, although there's this short-term toxicity requires ICU admission. I mean, there's still those patients who had a very durable CR with potential for long-term remission. Now, with the advent of nivolumab ipilimumab, I think the role of IL-2 is certainly diminishing. When we see the 30-month follow-up that presented at GU ASCO, we see that the CR rates tend to be very much durable. The CR rates were 11%, and over 90% of them were durable. Patients had stopped therapy and maintained that CR rate. So clearly, as we get more and more follow-up, nivolumab ipilimumab certainly looks to be playing a role in providing a durable remission for these patients, comparable to or even better than that seen with IL-2. So I think the role of IL-2 certainly is diminishing in these patients.
I completely agree. So since we've seen the from ESMO 2017, when we first were presented with the CheckMate 214 data, I think we've stopped giving any high-dose IL-2 to patients at Duke. I want to pick up there, and from our discussions around ipilimumab, nivolumab, that 10.8% complete response rate, we're really shooting for complete responses in these patients, and really trying to maintain those complete responses. So there was an interesting segment in that in the 30-month survival data that the patients who discontinued for complete responses, actually about half of them didn't have to go back on treatment at the 2-year mark. So this is a really great thing for our patients if they can have some good treatment-free intervals, and we were seeing some data out of CheckMate 214 about treatment-free survival periods, and that's a really meaningful time where patients are off treatment, they're not experiencing these toxicities. I think it's clinically meaningful.
Interesting. And staying with this theme of IL-2, when I think IL-2, I often think of the Huntsman. You are a very high-volume IL-2 center. Has your practice changed at all now with new immunotherapy regimens?
Similar to Duke, what Tian said. After we saw the data of complete responses happening in almost 10% patients, and that was the whole reason we pursued high-dose IL-2, for those complete responses. And also, IL-2 services in most of the university hospitals, cancer centers, is also driven by local referrals from practicing community oncologists. It was much easier to get those referrals 10 years ago when we did not have anything to treat our patients with. So only option was high-dose IL-2. Now, moving forward 10 years, we have more than 13 different treatment options for these patients. And there is a lot less enthusiasm for community doctors to refer patients for high-dose IL-2. So I think both the really astounding efficacy of ipi-nivo combination from the perspective of complete responses and decreasing referral, we have also stopped giving high-dose IL-2.